The views expressed on the Jerry Cahill CF podcast are that of Jerry Cahill and guests, and not necessarily those of the Boomer Esiason Foundation. Nothing on the Jerry Cahill CF podcast should be considered medical advice. Such advice can only be given by a physician who is experienced with cystic fibrosis. The Boomer Esiason Foundation, Jerry Cahill and guests cannot be held responsible for any damage which may result from using the information on this podcast without the permission of your medical doctor. You're listening to the Jerry Cahill CF podcast presented by the Boomer Esiason Foundation and jerrycahill.com.
Welcome to Jerry Cahill's Living, Breathing, Succeeding series, The Path Forward with CF. This show is made possible through an educational program from Columbia University Medical Center to the Boomer Esiason Foundation. Today we'll be speaking about the future of double lung transplant with Dr. Joshua Sonett. Dr. Sonett is best known for his work on the multidisciplinary treatment of lung and esophageal malignancies.
I can say in New York, even though we have so many people, the organ donation rate is not as high as it should be. It just, everybody's working on that, but that is the sad fact right now. The availability of organs, we're attacking on two fronts. One is the political, say, social side. We're trying to optimize the waiting list system through research proving that better sharing without geography would benefit all patients, not just our center. It's to benefit any patient that needs a transplant, regardless of what center they are in. Geography in the near future hopefully will have less impact. So right now, if the limit is, say, 250 miles, we're hoping that it'll go to closer to 1,000 miles. So the sickest patient in a 1,000-mile radius would get that lung. And that's really what this is about. Two, we're certainly advocates in trying to sign people up for lung donation or being organ donors, which is critical. And I would hope, and we're advocates for what's called opt-in versus opt-out. In the future, like some other countries, hopefully we're all born with the implicit that we're organ donors. And that if you don't want to be an organ donor, you opt out or sign your card that says, I'm not going to be an organ donor, rather than having to opt in. And that's been shown to improve organ donation rates throughout the world. We've seen a lot of social change happen over the past 10 years just because the will of the people showed that it was the right thing, marriage equality, things like that, that despite bad laws, the right things bubble to the front. So if we can change public perception that organ donation is an expectation, and only if you have some really reason not to organ donate, which is your privilege, but it should be the expectation that you donate organs. And for those that are watching this, if you're listed as an organ donor, that has no effect on how you're taken care of when you show up to an ICU, an emergency room, or in an accident. You're taken care of. Every doctor, every nurse wants to take care of you regardless of whether you're an organ donor or not an organ donor and get you better. Because there are some rumors that that's not true, but that's not true. Can we keep lungs alive? Experimentally, we've done some work here at Columbia called cross circulation. We're taking that to ex vivo. So with ex vivo, we're showing that if we use, say, blood and just sort of a special fluid on the ex vivo machine without being connected to a person, that we can keep lungs alive, and this is where it's going, for 2 to 3 to 4 days, kind of like an incubator. And then we'll incubate those lungs to heal them from whatever their problem is. I'll make a wild prediction. CF will be the first group of patients that we stop transplanting than any other patient because of the new medicines and treatment for CF. I think that is not far, that's going to happen before I retire. So fixing lungs and optimizing lungs from other humans is basically standard transplantation. And then can we make lungs from de novo lungs? And then the third option is, can we take lungs from, say, animals, probably large swine or pigs, believe it or not. Their lungs are pretty much close to ours. And instead of raising those animals for pork, we raise them to be lung donors. And there are some really exciting research pointing to that is an achievable goal in the very near future. We have a giant research team working on trying to figure out how that will work, and the immunology, or basically the molecular medicine to make it a human lung, a human body, except some type of animal organ. And then the final frontier is we have stem cell programs here where we're trying to rebuild lungs with new stem cells. And that's what I call the moon launch, the Mars launch. We're trying to rebuild lungs from scratch, and you see all sorts of exciting press about that. They've grown lungs and they've transplanted lungs in mice. We are way, way off from ever being able to yet take lungs that are made from a scaffold, totally lungs from stem cells, and put them into a patient. But we're not far off from learning a lot of valuable lessons as we try to do that. So for instance, we're taking the lessons we learn when we're trying to build whole lungs and taking some patients, say with not cystic fibrosis, but other diseases, and rebuilding their own lungs within them. So they don't have to get transplants. We can wash out their old lungs, their old cells, give them new cells, and then rebuild their lungs. Will we have an artificial lung in the near future? Yes and no. So ECMO, if you think about it, again, an ECMO is taking blood out of a patient and giving it oxygen and taking away CO2 and putting it back in. And it used to be that machines for ECMO were huge. They took up half the room. And now they're about this big, okay? And probably within a year or two, they're going to be this big. So as those machines and technology gets better and better, and it's rapidly evolving, a patient who's on ECMO, what's called ECMO will be more like an artificial lung because it'll be on their side and they'll be able to walk around. So that, in essence, is an artificial lung. You say, well, why don't you just call it an artificial lung? Because the way that they change the oxygen in that is basically like an oil filter in a car. And it goes through that oil filter and it gets oxygen and takes the CO2 out. Presently, the filters that we use to do that work can work 2 weeks, 6 weeks, maybe even 3 months, but they wear out and they have to be changed. And so it used to be that if a patient with cystic fibrosis came in and couldn't breathe and got on the ventilator, it's possible that their days were numbered. And now we know that we can routinely put them on the ECMO, where they can walk around, not be on the ventilator, and with being on that ECMO machine, because of how sick they are, their lung allocation score, their LAS, will go up high, so that most patients with CF, and we can't say everyone, but most patients with CF, we're going to get you to transplant. You will get your chance at transplant, as long as there's not some other intervening factor. That will get, and the ECMO will get you walking around, your score will go up, and if there's no other major reason, like another problem with your kidneys or blood not matching other recipients, that we can get lungs within a couple of weeks for most people on ECMO nowadays. When I first came to Columbia in 2001, we used to be able to just keep people on ECMO really 3, 5, 7 days, and then all sorts of stuff would start happening that wasn't good. Now we've had patients on, not just, when I'm talking about ECMO, not just patients waiting for lung transplant, but patients that were improving lungs that have been injured for other reasons for 3 months. But we've had patients wait and get lung transplants at least after 6 weeks of ECMO and do fabulous. The future of CF and transplant looks bright. It's for patients that need transplant, the ability to get lungs will better, the ability to do it with a smaller operation and less impact is better. And then the real impact, which we're working on at Columbia, and clinical trials will actually start, I'd say, within 3 to 5 years. We'll be able to implant lungs and not give medicines to stop rejection, because the lungs are going to be treated and the body's going to be treated so that the body thinks they're their own lungs. And that's sort of what we call the Achilles heel of transplant presently. All the medicines all our patients have to take to keep those lungs from being rejected, and frankly, chronic rejection, which is the number one reason lungs wear out. In the not too near future, we'll be able to transplant lungs, and we'll never get rid of rejection, but we'll have it so much better that I think routinely patients will get new lungs and be living 10 or 20 years in the 80-90% range. Any patient that's transplanted right now has to take, you know better than I, Jerry, a handful of medicines every day to keep the body from rejecting those lungs. And it's a chore to take them, but it's a blessing to be able to take them that it keeps from rejecting. But every medicine that we do to stop rejection can increase infection, increase skin cancer, increase all sorts of side effects, because every medicine has a side effect, especially as you take it over the time. And that is wearing on the body, and it's also imperfect, since 50% at 5 years of patients at least are going to have some form of rejection. We have a huge effort led by Dr. Megan Sykes to try to change that here at Columbia, and using research to use the body's immune system and the donor and bone marrow and stem cells, so that in the future, patients won't have to take immune medicines. And that's not so far in the future. Trials for kidney transplant are already underway or in process, and the harder organs like liver and lung will be soon to follow. But once the proof of concept is finished, that we can transplant lungs and not use as much or any immunosuppression, it's going to dramatically change the field. So, like I said, I think for cystic fibrosis, I think that's going in the right direction, where we're fixing. The way I would like to see transplant is that first fix the diseases that we need, whether it's cystic fibrosis, pulmonary fibrosis, pulmonary hypertension. As we get better at transplant, and some of the lessons we're learning from Dr. Sykes' team to try to optimize future transplant, we're learning how to fix lungs before they need transplant. So I see a future where a significant number of patients, A, won't need transplant, and B, because of ex vivo lung rebuilding, the combination of keeping lungs alive ex vivo and the lessons we're learning trying to build completely new lungs, we're going to be able to fix lungs that the organ waiting list is basically disappear, and we're going to design lungs for donors on a routine basis. And we have a large experience with patients getting second transplants. So if you took care of your lungs well and your body is still doing well, and your lungs, for whatever reasons, are running out of steam, usually chronic rejection, we can and we will perform a second lung transplant, and even sometimes a third, but hopefully not. And the results for doing it a second time, I can tell you at Columbia, are just as good or better than the first time. It's only about 6 to 10% of the transplants presently that are being retransplanted. Unfortunately, a lot of patients, it's mostly CFs that get the retransplant, because a lot of the, if you think most of the transplants patients we do are emphysema or pulmonary fibrosis who are maybe in their high 60s when they get it. By the time they need a retransplant, their body has other issues. It's really about how good the rest of the body is around those lungs. The retransplant itself isn't particularly harder. It was started out with lung transplant being a scary process. Well, of course, any operation is scary, and certainly the magnitudes of lung transplant is scary. But for those of you, you shouldn't want a transplant per se, but you should look at it as a positive, a way to get better. And we know you're going to get better because almost everybody comes out of the surgery and does well. We have issues afterwards, but it's going to give you a chance for survival and live a totally normal life.